Hello, welcome and kumusta. Thank you for joining me. This is Hao, your occupational therapist, and welcome to OT Conversations. Another observation that I've had over the years is that there is a lot of interest and a lot of talk with regard to a model of practice. And students, clinicians alike always ask, how do you apply the models, the occupational therapy models, in your practice in the body of work? And there are very popular models out there. You have the model of human occupation, you have the Canadian model of occupational performance. These are the very essential ones. You have the Kawa model. But these models look at a person in general on how we view a person. And I think there is an element of mistake in focus. So I think our focus is wrong. Rather than focus on models of practice, we should be focusing on the frames of references. These are the ones that will guide you in terms of principles of treatment and intervention. And it will depend on the problem. You don't think of the model and fit the person to a model. That's what tends to happen with models. You have a model and then you fit the person to a model. But the way around this is you start with the problem and then you need to find out which models or which frames of references addresses these problems. Let me say that again. If you want to start looking after patients and you want to help them and you want to address their problems, rather than thinking of the model to fit the patient, you need to think of the problems and find out which frame of reference addresses this. Okay, let's use it in practice. For example, if you are looking after a patient who's had a recent pneumonia and the person is recovering from being ill, and what was the intervention? So the first line of medical intervention here would have been just tablets and antibiotics. Those are the first line. Now, that controls all the biochemistry and all the microbiology inside the body, all the tablets, all the antibiotics sorts the infection out. But there will be some residual problem. And the residual problems here can either be a lot of production, sputum production, and what happens to all of these secretions is that it does not allow the lungs to maximize or to function properly because it stops the lungs from getting a lot of oxygen. In a severe form, if it's gone bad, all of these secretions will impair the person's ability to take in some oxygen. Just that. Okay, that's the basic medical part of it. But what about for occupational therapy? We're not respiratory therapists, so we don't need to worry about those things, although we need to understand. What we need to understand as well is what is affecting the person's functional ability. And the one thing that will affect the person's functional ability will be their endurance level. Okay, so now here is the problem, endurance. Okay, endurance is a performance component. As an occupational therapist, you look at their ability, their occupational engagement, and then you'll have to define the ADLs. What are the ADLs that can be affected? Functional mobility, dressing, person's ability to go to the toilet, engage in toilet hygiene, showering. And then you analyze what would stop a person from engaging in those things or what's causing the difficulty. So the one that is causing the difficulty obviously would be the endurance level. Endurance. Now, what frame of reference is addressing the issue with endurance? This is when you have to use your frame of references. So you started analyzing the ADLs. Yes, there is a problem with ADLs. What's causing the difficulty? The difficulty is endurance. And what's causing the endurance problem physically? Yes, there is a lung situation. Is the lung situation being addressed? Yes, that's being addressed. And it's been addressed through the medication or through whatever functioning respiratory therapy or physiotherapy to clear the secretions. Yes. But despite all of those interventions, there remains a problem with engagement because the effect of those problems is has deteriorated the patient. So it got the person's endurance low. Endurance. And what is the treatment for endurance now? This is where you would think about the frame of reference. And the one reference that claims to be addressing the endurance is the biomechanical frame of reference. Very straightforward. And now the biomechanical frame of reference has principles on how to improve the endurance. And how do you improve the endurance, they say? It is by providing a low resistance activity and sustaining it over a period of time. So low resistance and the measure of success would be a long period of time. So now you'll have to design what will be a low resistance activity. Now you have to come up with an activity. Do you want to have an activity where the person is sitting down? In which case you have to get the person to do something. And when you are thinking of an activity with endurance activities, it has to be something that involves big movements or movements of bigger muscles. So a typical scenario would be walking would be a scenario that's big movement. But if the person cannot engage in walking because it's still very heavy, then tone it down. You have to think of an activity that is a bit less demanding than the walking. Then you need for a person to do activities that is in sitting. And then you need to think of things like reaching activities, picking something, activities that involves repetitive movement. That's one way to address the endurance. And when you're dealing with endurance, that's the start, right? Say you get a person walking, and I've seen a few people and a few therapists who prioritize the quality first. So they get the person to start walking with a stick, and they start walking even without a stick, and the person's endurance is very low, that it is affecting their balance. Falls, which would be the balance, would be an effect of somebody who has poor endurance. Endurance and tolerance is the one thing that you need to address first. How do you do that? If your intervention is walking, get them to walk as frequently as they can. You can even get them to walk in between parallel bars. And parallel bars are there so that the person can walk from one end to another with seats and chairs on either end. So the person can stand, walk short distance, turn, and sit. Yeah. So you are using the parallel bar to increase the endurance because those bars are just there technically to hold on to something. So a person can exercise going to and fro. Now the parallel bar is not available all the time because you're in the ward. What you would do is you'd get the person walking. And when you're walking, like I said, sometimes people would prioritize walking using a stick. And the person is so lacking of confidence because their endurance is not good and their balance is impaired. So they would not want to walk. What you need to do is get them to do a lot of walking by using an aid that will allow them to feel safe. Safety, just to let you know, safety is very important. So there's a lot of things in here. Okay, we're now dissecting a simple activity and a simple rehab plan. And now, just going back to the original point of this conversation, we're talking about the frame of reference. And the frame of reference is biomechanical frame of reference. So you would use these biomechanical frame of reference for all those people who's been deconditioned. And for what would decondition a person? People who have had some respiratory problems, for example, for people who's had cardiac problems, for example. So these are the ones that you would do. Focus on their ability, sustain the activity, enable people to do as much as they can. And this is the frame of reference. Now, for example, different case scenario where a person is delirious. Ooh, that's a big word. That's a big problem, right? Now you have delirious is just a general term for a lot of things that are going wrong, right? Then you have to break things down. What is the situation? Say for somebody who's had a delirium, the problem is orientation. Okay, they wake up, they don't know where they are. Okay, so orientation. What frame of reference will be dealing with orientation? So now you can be using cognitive frame of reference. You can look at the case scenario using a cognitive disability frame of reference, Claudia Allen, or it's purely cognitive disability and cognitive frame of reference. And what are the techniques for these frames of references? You have techniques such as repetition, reorientation, teaching and learning style and teaching and learning methods. And you need to use this. And that's one approach. You can actually use a model of human occupation as a frame of reference because MOHO is also a frame of reference. How do you want to do that? When you want them to be reorientated, you can tap on improving their routines and habits. So sticking to a routine and habit and giving them a proper reorientation activity, that would be the application of that. So there you go. Identify the problem. That's one. Next thing is find out what frame of reference is suitable to address those problems. Oh, after identifying the problems, identifying the problem is one. That's good. Next thing rather is understand the problem. Because problems are problems, but they have different reasons and there's different ways on how this would present themselves. What do I mean by that? If we go back to the example of orientation for somebody who is delirious, why is there disorientation? If they've just woken up from critical care, yes, that's understandable. If they are recovering from after surgery, yes, that's understandable. So that's different. Whereas somebody who's had disorientation because of a stroke or a head injury, then it becomes a different scenario altogether. It is no longer delirium because there is an organic problem. And so your treatment and frame of reference will change. What do I mean by that? If it is only disorientation, then yes, cognitive retraining, teaching and learning, behavioral strategies, that's one thing you can do. But if there is an organic reason, then you can use the techniques and the principles using the cognitive disability frame of reference by Claudia Allen, or some of the neurological techniques. But some of the neurological retraining techniques are mostly focused on the physical rehabilitation and with less emphasis on the actual ecological interventions. Okay? Do we want more applications? Okay. Say you have hands, for example. person has had a hand injury and they develop a situation that needed where the hand needed to be repaired. And if you do that, post-surgery, the hand gets referred to you. And what would be the problem? Swelling. And swelling, what frame of reference addresses swelling? Again, this is a biomechanical frame of reference, and there are some techniques on how to address the swelling. Easy, that's fine. Range of motion. You want to maintain and you want to prevent. What frame of reference talks about the range of motion? And you talk about mechanical frame of reference. Good. That's straightforward, isn't it? What about if you want to do a splinting for the hands? Do you want to do that? Yes. If you want to sustain and maintain the tissue length and you want to prevent it from shortening because of the surgery and you want to maintain that length, then yes, that's a biomechanical frame of reference. So you see, you have to think of the problem, analyze the problem and understand the problem, and then think of a frame of reference that will be suitable in addressing those problems. Let's use the hands as an example once again. And with hands, it shortens. Say the hand is shortening. It's assuming a mass flexion pattern and position because of a tonal issue. And you want to sustain that soft tissue length. And what do you use? Okay, so there is a problem. The hand is at risk of contractures. What do you want to do? You want to prevent that contracture from happening. Now, there is a problem because it's a stroke. Now you have to understand the nature of it, the nature of spasticity. Then you did. Now that you understand, now what's the frame of reference that would be best suitable for this? It would be NDT or neurophysiological or sensory motor approaches. You're addressing the tone. How do you address the tone? You sustain it by sustained stretch. What can sustain the stretch? It will be a splint. So you'll put the splint there and it will maintain the hand position. So you see, the splint is used in biomechanical. It is also used in the neurodevelopmental or sensory motor techniques as well. So same treatment, but really it's a different reasoning altogether. Lots of important lessons here. But what I want to say is it's really paramount, it's really important that you as a clinician will need to understand all of the frames of references that is available to you, and you should not be confined into one frame of reference. You should know this because there will be multiple problems that will come your way, and these multiple problems, there will be some frames of references that will address this problem. I have yet known a problem that is not addressed by a frame of reference. I know there was one time where the person came to me and she asked me if I can inflate the tire of her wheelchair because she's finding it difficult. See, even with that, you can still find a model or a frame of reference. Yeah. What was the issue there? It was an issue of value. Okay. Because it's important to her. It's making it difficult for her. So what would be the frame of reference that will address this value? What frame of reference talks about value? Model of human occupation. So even with that, model of human occupation falls in. That's why everybody loves model of human occupation, because it covers the entire thing. There is a lot of scope for the model of human occupation, particularly when you're addressing the performance component, or which is down at the bottom, which not a lot of people are paying attention to. What do I mean by that? Down in the performance side. We'll talk about model of human occupation at some point. There you go, guys. Whoa, lots of waffling, lots of talking, lots of exploration, and lots of talk. I hope you picked up a little something. Hopefully, it will make your practice improve and get better. Hopefully, it gets you thinking about frames of references, which is so important to an occupational therapist. Our profession looks at a lot of problems. It's the problem of human occupation, and there are problems of the performance context, and there's problem of performance components, and all of these problems needed to be addressed scientifically, and the scientific frameworks for this will be the frames of references. Okay, just remember, guys, anything you do matters and has an outcome. Until next time, bye.
If you enjoyed this podcast, talk to your friends and colleagues about it. Like it, subscribe, share, and do what you can to appease whatever algorithm that is at play. Just remember, guys, anything you do matters and has an outcome. Until next time, bye.